Ventricular tachycardia. We're going to identify the origin of ventricular tachycardia in the cardiac conduction system, recognize VTAC on the ECG monitor, distinguish between sustained and non-sustained VTAC, distinguish between monomorphic and polymorphic ventricular tachycardia, and distinguish between VTAC and ventricular flutter. Ventricular tachycardia is one of the deadliest arrhythmias that you will encounter in clinical practice. In reality, VTAC can produce a spectrum of disease ranging from a completely asymptomatic presentation to sudden cardiac death. It's the latter of the spectrum that gives VTAC its reputation. It is sudden and deadly. The presence of 3 or more ectopic ventricular complexes in a row with a rate above 100, so that's going to be one of the key characteristics. The rates are usually between 100 and 200, but can be higher. You can have monomorphic ventricular tachycardia, where all the complexes look exactly the same, or you can have polymorphic ventricular tachycardia, where the morphologies vary from beat to beat. A word of caution, all of the ventricular tachycardias that we see, we're going to treat it as a ventricular tachycardia until proven otherwise. And usually we don't make it to the point to where we prove it otherwise in the field. So non-sustained ventricular tachycardia lasts less than 30 seconds. It occurs paroxysmally and then it converts out. Sustained ventricular tachycardia lasts longer than 30 seconds, or it requires some intervention to break the rhythm. And then incessant ventricular tachycardia presents most of the time. So here's a image that helps you distinguish between the two. So our non-sustained ventricular tachycardia, that's going to be 30 seconds or less, and then our sustained is greater than 30 seconds, or we need to intervene to break the cycle. So rhythmically speaking, VTAC is a faster, deadlier form of accelerated idioventricular. Characteristics: wide bizarre complexes. It may have a left bundle branch or a right bundle branch configuration. ST and T wave abnormalities. The presence of Josephson's sign or Brugada sign is also possible. It's a regular rhythm, except at the beginning when it converts into the VTAC, and it's usually triggered by a PVC. These are all ventricular tachycardia. Morphology includes a wide QRS complex, but it's not always going to look exactly the same, and most of the time it's going to depend on where the reentry mechanism is and the origin of the conduction, the ectopic foci. VTAC is usually a very regular rhythm except at its onset, because VTAC is usually triggered by a PVC. The rhythm can show some irregularity at the onset. So this is just an example of a non-sustained monomorphic ventricular tachycardia that was triggered by a PVC. When an episode of VTAC comes on so fast as to obscure the morphology of the individual waves and segments, it is known as a ventricular flutter. The rates are much higher at 200 to 250. They can vary depending on the patient and the clinical scenario. Clinical manifestations of ventricular flutter are the same as for sustained VTAC. The patient's typically more unstable because of the higher rates associated with the V flutter. If the patient is hemodynamically unstable, electrical cardioversion or defibrillation is strongly recommended. So here's an example of a ventricular flutter. So it is a wide complex, but it's at a very fast rate. So my rules for ventricular tachycardia, usually it's going to be between 100 to 250. The atrial rhythm is not distinguishable. The ventricular rhythm is usually regular. So that's one of your big differences when trying to differentiate between VTAC and ventricular fibrillation, is that ventricular tachycardia is going to be organized. Is there a P wave before each QRS? It may be present or absent, but they're not going to be associated with the QRS. And the length of the PR interval is going to be non-existent. The QRS complexes will look alike, but they will be wide in complex. So this is just showing you an example of a ventricular tachycardia. So looking at this rhythm, it's very possible that the ectopic area originated here, and it's most likely a re-entry mechanism that's causing this ventricular tachycardia to occur. My rate is around 180. I have no visible P waves, no PRI, but I've got a QRS that's greater than 0.12. So since I've got a wide QRS and a rate greater than 100, this is VTAC. So ventricular tachycardia is classified based on the assessment of the patient's clinical presentation, either pulseless VTAC or VTAC with a pulse. Immediate treatment is based on the presence or absence of a palpable pulse. Obviously, if they do not have a pulse, then we're going to move straight to the American Heart Association pulseless VTAC algorithm, where our very first thing is going to be to start CPR, and then shock is very important. Treatment of VTAC with a pulse is based on the patient's clinical picture, and if they've got a pulse, we're going to move to the American Heart Association tachycardia with a pulse algorithm. If they're hemodynamically unstable, immediate cardioversion at 100 joules is recommended. And if they're hemodynamically stable, then we're going to consider using amiodarone, 150 milligrams over 10 minutes. Causes: myocardial ischemia, hypoxia, electrolyte imbalances, increased anxiety, physical exertion, or most likely underlying heart disease. It may be a perfusing with a palpable pulse or non-perfusing. Due to the rapid heart rate, the ventricles do not have time to empty and refill, so ventricular filling is altered, atrial kick is altered, the Frank-Starling mechanism is altered, so your cardiac output is going to be compromised. And your treatment is based off of what we just discussed. Do they have a pulse, and are they hemodynamically stable, or are they hemodynamically unstable? So if ventricular tachycardia is perfusing and stable, treatment consists of oxygen administration, IV, and pharmacological intervention. If the VTAC patient becomes clinically unstable, as evidenced by hypotension, shortness of breath, altered mental status, synchronized cardioversion is indicated. So in the case of your tachyarrhythmias with a pulse, synchronized cardioversion is always going to be your first step if that patient is hemodynamically unstable. If VTAC is without a pulse, treatment will require immediate unsynchronized cardioversion or defibrillation, and that is crucial. You've got to start CPR, and then you've got to shock this patient. Remember, it is treated the same as ventricular fibrillation, and you've got to be aggressive and immediate with your treatment. So looking at a few examples, we've got a rate of 200, a wide complex, no P wave, no PRI. This is a ventricular tachycardia. Same thing here, except this patient's having a very large AMI as well, and this will probably convert to ventricular fibrillation if we are not aggressive. Now the rate's only 140 on this patient, but it still is VTAC. In this rhythm, you've got wide complex at a real high rate. The blue arrow could indicate pseudo S wave, or it could be the morphology of the S wave itself. This is a ventricular tachycardia at a rate of around 110 to 120. The blue line on this strip may be a notched T wave or a P wave with a prolonged PRI, but it's still insignificant to us if we're in the field trying to make a determination if we're going to treat this patient. Now this patient only has a rate of 120, but it is a wide complex. It's greater than 100, so again it's going to be a ventricular tachycardia. The blue arrow on this one indicates a possible Josephson sign, which is a P wave, or it could just be part of the S wave. And it's at a rate of 150, wide complex, so it is ventricular tachycardia. This one, we actually have a PVC that occurred right after, so it had an underlying sinus rhythm. This PVC occurred and actually triggered, so this is a paroxysmal ventricular tachycardia. This one is an extremely high rate. The book calls it a ventricular flutter, but will treat the same as a ventricular tachycardia.